Hello, everyone, and thank you for joining us for today's webinar on community benefits, equity-driven partnership models. We're excited to see so many hospital and HMO staff tuning in to what we hope will be a very informative event. My name is Noam Yousefi. I'm a healthcare analyst in the healthcare division of the Massachusetts Attorney General's office, and I manage the state's community benefits program. It's been a pleasure connecting with many of you as we approach the FY20 community benefits reporting deadline on July 31st. As many of you know, the AGO's community benefits guidelines emphasize the importance of integrating social determinants of health into a hospital or HMO's community health needs assessment and community benefits implementation strategy. We decided to put this webinar together to showcase models for community benefits programs that address social determinants of health through a health equity lens, and to encourage hospitals and HMOs across the state to embrace equity-driven best practices when engaging with community members and organizations in developing programming. Over the next hour, we'll hear from partnerships between Massachusetts hospitals and community-based organizations who've worked together to identify and address upstream determinants of health through a community benefits program. They'll present their approaches to incorporating the voice and leadership of a target population in program planning and implementation. Before we begin, a few housekeeping notes. Please make sure that your mics are set to mute. Audience members are invited to use the questions function to submit a question for presenters if time permits. And if we don't get to those questions, they'll all be saved for us to review at and follow up with you at a later date. As a reminder, this session is being recorded and will be made available to community benefits filers registered with the AGO Community Benefits website shortly after the webinar. And as always, please feel free to reach out to our office at cbadmin@mass.gov with any questions following the webinar. So before I introduce our panelists, I wanted to share some trends from fiscal year 19 reporting under the AGO's updated community benefits guidelines, and to tie these back to some of the key equity principles in our guidelines. As many of you know, in 2017, the AGO convened a task force comprised of hospitals, health plans, community health centers, public health offices, and community leaders to examine how to promote hospital and HMO community benefits investments in addressing upstream systemic determinants of health and health inequities. Informed by input from this task force, the AGO published updated community benefits guidelines and tools centered around the following principles. First, we made changes to reduce unnecessary administrative burden by harmonizing federal and state requirements where appropriate. Second, we developed new tools to improve community benefits engagement and planning and implementation of community benefits programs. Third, we sought to increase transparency into key aspects of the community benefits process and expenditures. Fourth, the new guidelines encourage investment in statewide priorities and key social determinants of health. And finally, these new guidelines aim to promote regional collaboration and learning. The most recently published hospital and HMO reports for FY19 activities and spending are the first to be submitted in accordance with the updated guidelines. And in the next few slides, I'll go into further detail around some of these principles and share some insights based on FY19 reporting. First, the guidelines provide guidance on how to integrate the social determinants of health into a hospital's community benefits plan. The guidelines anchor the discussion of social determinants of health with the Boston Public Health Commission's Health Equity Framework. This framework illustrates how racism has an independent influence on all social determinants of health, and that racism in and of itself has a harmful impact on health. Our guidelines aim to assist hospitals in recognizing and addressing the role that racism and institutional bias play in impacting health outcomes in their communities. It's especially important that hospitals consider this framework when identifying and prioritizing community needs. We also aligned our guidelines to be consistent with other state initiatives to build long-term capacity in addressing common health priorities across the Commonwealth. On the left side of this slide, we list the 4 statewide focus issues identified by the Executive Office of Health and Human Services, which were adopted in the community benefits guidelines as areas that hospitals should consider as they plan and implement community benefits programs. The guidelines also encourage hospitals and HMOs to consider 6 priorities adopted by DPH in its determination of need community health improvement plan, which are listed to the right of the circle. These health priorities underscore the importance of investing in key social and economic factors that impact health outcomes, such as education, employment, and housing. The new community benefits reporting system asks filers to report which of their community benefit programs and expenditures are aimed at addressing these shared health priorities. As you can see here, about a quarter of FY19 community benefits program spending was aimed at reducing chronic disease, with significant funding allocated to mental health and substance use as well. About half of program spending in FY19 was not reported in connection with one of the 5 statewide priorities, but rather aimed at addressing another health need identified by the community. The AGO's new reporting system also offers hospitals and HMOs a more comprehensive, robust selection of attributes or program tags to provide further transparency into the health needs and target populations being addressed through programming. Program descriptors include program type, age group, gender, race and ethnicity, region and environment served, language and health issue, and vulnerable populations, such as individuals with disability status, domestic violence history, immigrant status, or incarceration history. The community benefit guidelines also encourage hospitals and HMOs to engage and collaborate with their community at the highest level feasible at each stage of program planning, implementation, and evaluation. We adopted the community engagement spectrum depicted on this slide in our guidelines, and it's used by community representatives in assessing a hospital or HMO's community engagement planning and evaluation processes, ranging from informing and consulting with community members to engaging in a community-driven or community-led approach, representing the highest level of community engagement. This same spectrum is used as an evaluation tool in the AGO's community representative feedback forms, which aim to solicit feedback on hospitals' level of community engagement in assessing community needs and in developing and implementing a plan to address the health needs identified in the process. This slide shows data collected from the FY19 community representative feedback forms, specifically from the question that asked community members to rate the hospital or HMO's overall level of engagement with the community in developing and implementing a plan to address identified health needs. Community representatives indicated that hospitals and HMOs vary widely in their level of engagement in developing and implementing a plan to address identified health needs, with many reporting high levels of community engagement. The community benefits guidelines also encourage hospitals and HMOs to collaborate with other hospitals, insurers, local public health departments, and community organizations in conducting community health needs, developing implementation strategies, and sharing best practices. Many Massachusetts hospitals and health plans have or are engaging in joint CHNA and implementation strategies to come together in addressing regional health needs, and these joint efforts have the greatest potential to impact community-wide health disparities in the Commonwealth. So that was just a brief overview of some of the findings from FY19, and to set us up for our wonderful panelists today, I'm going to stop sharing my screen. And let's see. So folks should be able to see all of our panelists here today. So let's turn to our wonderful panel of speakers who are representing 3 partnerships in Worcester, Lowell, and Springfield between Massachusetts hospitals and community-based organizations. Each of these partnerships has worked to identify and address an upstream social determinant of health through a community benefits program. And through their partnerships, these organizations have developed and refined approaches to incorporating the voice and leadership of a target population in program planning and implementation. I'll start us off by introducing the speakers from each partnership, and then we'll hand it off for each partnership to provide a brief overview of their model and goals. After these brief introductions, we'll move into a discussion about best practices and lessons from each of these community benefits programs. And if time permits, we'll answer some questions from the audience. And please submit any questions using the questions function in the GoToWebinar tab. So let's get started with our first partnership. I will just quickly unmute our speakers. Okay, so joining us are Monica Escobar Lowell, who is Vice President of Community Health Transformation at UMass Memorial Medical Center, and Casey Burns, who's the Director of the Coalition for a Healthy Greater Worcester. Monica and Casey, thank you so much for joining us today. Do you mind taking 2 to 3 minutes to share a brief overview of your partnership model and how this program aims to impact identified health needs and target populations? One second, let me make sure we can hear. Let's see. All right, Casey, you should be unmuted.
Can you hear me? I didn't know. Does Monica's audio work as well?
I'm here. Can you hear me?
Yes.
Excellent.
All right, go ahead, Casey.
Sure. So I can say the Coalition for Healthy Greater Worcester, we're CHNA, the Community Health Network Area 8. And really the coalition and the CHNA 8 has gone through a number of iterations, all with kind of a long-standing relationship with UMass Memorial. We have worked on and collaborated in partnership with community members, both the community health needs assessments as well as resulting community health improvement plans, or CHIPs. We have just released our 2021 CHIP and are engaging in a partnership on our 2018 community health assessment. And since 2015 or so, we've really kind of refined and focused efforts with the CHNA and the Coalition for Healthy Greater Worcester on being the scaffolding for the community health improvement plan. And so I'll kind of talk through what that looks like when we get into the next question. But it's a really interesting model where we are the body for community engagement, assessment, capacity building for public health efforts, really accumulating around our community health improvement plan as our framework. But like we often say, it's the community's plan. Our plan is to provide the best scaffolding to provide for empowerment and leadership throughout that plan and the deepest engagement. And I think it's a model that's really worked well for us in our community. And I think we've been able to see some really strong impacts through the both the quality of the community health needs assessment as well as the responsiveness to community needs of our community health improvement plan.
That was a great introduction. Thank you so much, Casey. Next, I'll turn to our second pair of panelists. Michelle Snyder is the Regional Manager of Community Benefits and Community Relations at Leahy Hospital and Medical Center, and Jessica Wilson is the Executive Director of Mill City Grows. Michelle and Jessica, thank you as well for taking the time to chat with us. Do you mind taking 2 to 3 minutes to share a brief overview of your partnership model and how this ties back to your identified health needs and target populations?
Absolutely. Thank you for having us. It's so great to be able to learn from each other and share. So really, as Casey alluded to, the core of this partnership is based on need and an identified health need. So, once we determined as a hospital and heard loud and clear that lack of access to healthy food was something that was important to the community for us to address, we look towards community partners who were already addressing that. And Mill City Grows, we started our partnership with them, had been doing an amazing job at the grassroots level with data-driven, informed programs. So we're really a natural partner for us as we look to address that health need in our implementation strategy. And now I'll turn it over to Jessica to talk a little bit more about the program itself.
Thank you so much, Michelle. So we've been working together with Leahy for a long time as we've grown our community and school gardens program. Today, we have 20 community and school gardens in Lowell. We started out with just one, just a little less than 10 years ago. 8 of those gardens are designated as community gardens. So there are folks throughout the community who can come and have a plot with their household. We're really try to focus on making sure that the folks in those gardens live in the neighborhoods where those gardens are located. And over 75% of our gardeners do identify as low-income households. Our 13 school gardens are located within one of Lowell's public schools. And so they're a resource that all the students in that school are able to use throughout the day. We also, as a kind of like a hands-on learning lab for a variety of different classes. We also work with the schools to provide after-school programming in those gardens so that all the kids in the schools get a lot of opportunities to get their hands in the dirt and grow vegetables and kind of learn about gardening and nutrition as well. And so all of these gardens are operated by Mill City Grows staff with engagement from a community garden leadership team at each site. So in the community gardens, that will be, folks who are gardening in that space. They take a 3-week training with us about, and they learn a lot, not just about gardening, but about community organizing, about the history of racism in the food system, and really understanding what it means to kind of build a diverse community that acknowledges every single person. And in the school groups, it's very similar, except it's staff of the school who volunteer to be part of that. And it may include, parents of students, teachers, administrators at the school, and facility staff as well, who are helping out with of the space. And so that's a little bit about how our gardening program runs. But in addition to that, we really do food access for the whole community. And so in tandem with the community gardens, we have urban farms, a mobile market that distributes produce through a retail space, and then lots and lots of food education for all ages.
Great, thank you so much. Can't wait to dive into that partnership very soon. And so our last partnership that we featured today includes Katie Bruno, who is a public health and wellness program manager at Health New England, and Jeff Markham Jr., who's a program manager at Men of Color Health Awareness, or MOCA. Katie and Jeff, thank you so much for joining us today. Do you mind, just as the other panelists, giving us a brief overview of your model and how the model aims to address health needs and target populations?
Sure. Hi, everyone. Thank you for having us. I guess I'll start. So, MOCA, Men of Color Health Awareness, is conceived of as a men's health organization to address health disparities for men of color in the city of Springfield. Been doing that over the past 10 years. And part of that process, we've developed curriculum to introduce men to, healthy activities and start to recontextualize what it is to be a man coming from where we come from. And part of that process has always been about meeting men where they are. And one of the most important places that some men who are in need are in being incarcerated. So we were lucky enough a couple years back to start develop a relationship with the Hampton County Sheriff's Department. And I want to be clear that MOCA is not a program of the Sheriff's Department, but simply a contributor to some of the programming that is happening within the Sheriff's Department, within the Ludlow Jail, and also in the after incarceration support services. So MOCA began that relationship and was able to secure a small mini grant from Bay State Health and their Better Together grant process to start to go into the jail and actually deliver curriculum. And that went so well, and the relationship kind of lent itself to growing something a little bit more substantial and sustainable. And that's where our partnership with Health New England came in. They've been incredible partners in allowing us to redevelop our curriculum, which was based on men being in community and attending classes, for 10 weeks, going to being a part of the fitness program through the YMCA and learning things in those classes and attending meetings. Obviously, that's not possible with men who are incarcerated. And so what we were able to do is revise our curriculum a little bit to be more helpful to those men, to meet them where they are, and to engage in conversation with them about the transition once they come home. We were able to get into the what's called the short timers pod, where men who are coming out of prison within the next 90 days. And so we were able to develop a curriculum that was shorter, that spoke to what men in those circumstances were going through, and that we did all that with the partnership of H&E. And over the last year, obviously, we've taken a couple different roads. We were delivering curriculum to not only outside in the community to classes of 10 to 15 men, but within the jail system as well. And obviously that was not possible. So H&E has been an incredibly flexible partner in understanding that the level at which we could engage with men was going to be different. And I've been incredibly appreciative of that. I think that's a good overview. I think we'll get to some more kind of nuts and bolts related to the partnership in a couple minutes.
Yeah, that was great. Thank you so much. Thank you all for joining us today and for giving us that brief overview. Now I thought it might be helpful to dive into some questions that are specific to each partnership, starting with UMass Memorial and the Coalition for a Healthy Greater Worcester. So Casey, let's start it off with you. As you described it, the Coalition for a Healthy Greater Worcester has a mission to promote shared learning and broad engagement to improve community decision-making, health, and well-being for residents. Can you please share a bit about the Coalition's approach to engaging with the community and the framework that you use for identifying health inequities?
Yes, absolutely. And I had shared a couple of slides. Are we able to share those?
You should see those soon.
Awesome. So the Coalition for Healthy Greater Worcester, we just released, we use a few of these slides that are our recent Community Health Improvement Plan release just this March, but you can go to the next one.
Okay.
So this is just what I was saying. The Coalition is the convening agency for our CHIP. The CHIP is our document, our strategic plan, and our role was really to provide that scaffolding for the Community Health Improvement Plan. And you go to the next one. We follow the cycle of CHIPs and CHAs. Our first collaborative CHA, I believe, but Monica, please correct me, was in 2012, and then we had our first CHIP in 2013, but then have followed, we used CHA, Community Health Needs Assessment, was in 2015, which informed our 2016 CHIP. And that ran through the end of 2020. And so our 2021 CHIP was based on our 2018 CHA and the data from that. And really with our work with the 2021 CHIP, our intention was to be more upstream, equity-centered, community-driven, and focused in our approach. And if you go to the next one, we followed this process. This is kind of the outline of the process we followed in order to do that, to meet those ends of really being equity-driven, community-focused in our work. So like I said, our 2018 CHA was completed in 2018. But then in 2020, when we started our development process for our CHIP, we wanted to use more of to push us upstream in our approach. And so we convened a group of about 40 to 50 stakeholders over the course of 4 meetings, and we collaboratively completed a gap and root cause analysis. We both looked at the data from the 2018 CHA and said, what else needs to be disaggregated? What data needs to be updated? And then we did this fishbone exercise to help us connect points of disparities to systems of either social determinants of health and living conditions, or institutional inequalities, or social inequalities. So we would not be centering our conversation around health outcomes and individual behaviors, but instead the more structural issues as our framework. We then took that framework And we were able to get some funding from Health Resources in Action through the statewide DON funding program that was established in order to hire additional community engagement staff, as well as to select a team of cohort members, 10 cohort members from the community who had deep connections to the community, who they were then charged and who were funded and paid, and they were then responsible for leading our community conversations. We started with closed community, invite-only community conversations, and we very closely tracked the demographics of who was participating and created public systems of accountability to make sure that those who were participating were most representative of the communities facing health disparities. And so in November and December, we had 35 community conversations with 97 people where they dissected the kind of what results of the root cause analysis in order to recommend strategies. We then opened it up to the community through prioritization meetings in the community forum, where we then had our institutional stakeholders and partners come in and respond to those strategies and say, okay, so how do we make these more actionable? How do we build on current initiatives? But I think one of the real critical pieces was that we started with this very intentional process of the community conversations of those invited. We also tracked the demographics of the prioritization meetings, and it was a stark difference of who was participating, which I think helped to validate our process for this more focused way of coordinating our work. And then the next slide here is, we don't have time to go through it, but this is kind of the framework of the result of that process. Is our new chip looks very differently than our last one. It's much more upstream, focused on social determinants and policies and social inequities, and it's really set and it's more focused. It's separated into 3 areas: adopting municipal racial equity policies, supporting community-wide policy change campaigns, existing campaigns around things like police reform and housing assistance, public transportation, high quality broadband internet. And so supporting those policy campaigns and rallying our partners to support those. And then the bottom one is a prioritized strategy and action agenda, where these are more programmatic strategies to address mobilizing community services, providing trainings and services, coordinating navigation, community scaling, broadening navigation systems, addressing diversity in the workforce, and creating systems for public accountability through dashboards or other systems of democratized data. So this is really the framework that we're now diving into, and the coalition is helping to support that scaffolding for implementation. And you can go to the next, I think I just have one more, I think. And this is kind of just an overview of what that scaffolding looks like. We have a steering committee, we have a team of cohort leaders and staff, and then we have subcommittees and working groups that are going to be meeting regularly in order to create systems accountability to move this work forward, address stumbling blocks, and really be kind of careful and intentional how we're building on existing campaigns, and then communicating with a wider range of partner groups. And so really I think that's how I would describe the work. It's very hot off the presses, the work we're doing now, and we're continuing to kind of finalize and evolve this over the summer as well. We'll be kind of continuously opening up different opportunities for engagement.
Thank you so much, Casey, for that really informative overview. Monica, I'm going to turn it over to you. I'd love to hear a little about what in the HMO process led UMass Memorial to assume a central role in building these sort of regional coalitions around the health needs and disparities that have been identified, and how UMass leverages its role as an anchor institution in this regional public health planning.
Okay, yes, thank you. Well, the reality is that we hospitals cannot do this work alone. So way back, it was actually in 2008 that we first did our first community health needs assessment. And at that point, we said we really need to make sure that we are connecting with the outside world. And our approach has been to identify the need, partner, leverage resources. Health equity and social determinants of health have been front and center for us. And in order to get that work done, we're very good about taking care inside the hospital, but we needed to really be lifting our head and looking outside. And that's how we started in 2008. Our big partner it has been actually 13 years now, has a very good relationship with our Department of Public Health. Typically, hospitals have not done that. It's been an amazing partnership. They've been able to become regionalized and actually being recognized at the federal level, first one in accreditation in the state. And it's this building up with the idea that we need to work on these efforts together, and that the community knows best. What we think is important for us is not necessarily what our priorities out in the community. So having a community health improvement plan rapidly became important. So it actually was in 2012 that we formed our first equity CHIP with a equity base, meaning it crisscrosses across all their CHIP strategies. The other piece that is important is to make sure that we also are mindful of cross-sector collaborations, and that is noticeable also as you look at the CHIP scaffolding that Casey indicated, which shows that it's not just healthcare providers, but there's a whole bunch of broad key stakeholders involved. And Casey said it well. We know when we look back over the last 13 years, it is important to have an infrastructure that is supporting the coalition. I would say we spearheaded something back in 2008, but it's grown. It's not a baby anymore. It's morphed. Every time we do it, it looks better. And it's now the coalition, I can say, is a full adult that is recognized by the city manager. Philanthropy has looked at it and put their priorities as to what to invest. Well, let's see what the health assessment and the CHIP have in place. And it's really a tool that can be used to give us that roadmap. And so by having a coalition of this magnitude, it's also having not just a voice, but it's about shared responsibility and excuse me, and shared ownership. We are in this together. And so this is the best way that our investment in the coalition, and to the point where it is right now, it really has a life of its own, and it's very, very upstream. And it's important that we as hospitals continue to provide that support for that scaffolding. And by the way, the coalition is actually, as you get more successful, there are other groups that are willing to start to partner with a coalition and then make it possible to then partially fund the coalition.
Thank you so much to you both for providing those insights. It actually dovetails into one of the questions that we received from the audience directed at Casey. So Mike asks, great work, Casey. How do you keep people at the table, as this is not a simple or short process? What keeps them coming back?
I think a combination of things. It's different for every subcommittee and group. I think that one of the things that we've been successful with is kind of like we keep the big picture in mind, but we also do very actionable, bite-sized pieces of work where we're tracking, we're celebrating successes, and we're moving forward on very actionable agendas. So even if it's a big policy concern, we have steps that we've identified along the way, and we're really like documenting and communicating that we're moving towards those, and that people who are at the tables have meaningful roles in getting us there. I think that's one of the critical things. I would also say that really being careful and intentional, as I said, about not just naming leadership roles, but also sharing decision-making power and really articulating that. So people realize and feel when they are actually decision makers. And I think that, as Monica said, creates that kind of sense of shared responsibility. Third, I'll just quickly say is that we recognize that there are real obstacles and barriers for people to participate in these meetings, and we're making realistic accommodations in order to support overcoming those barriers, whether it be alternative meeting times, meeting structures of translation or childcare or food at meetings, or paying people stipends to be able to participate. I think also are like real strategies for addressing all participation.
Great. Thank you so much. I'm going to turn to our second pair of speakers, turning now to the Built Environment program that was previewed for us in Lowell. So Jessica, do you want to get us started? I'd love to hear a little bit more about your program's approach to addressing disparities in access to getting access to healthy food and green spaces at the root level. As you described, the partnership aims to improve long-term health outcomes for low-income families and immigrant communities by implementing these big changes to the built environment. So I'd love to hear your program's approach in doing that.
Absolutely, thank you. So we've, as I mentioned, we've been doing, school and community gardens for almost 10 years in Lowell. And part of our, our environment right now, Lowell's a very diverse community. It's a gateway city. We have lots of immigrant and refugee families that are coming to Lowell as their, the first home in the United States. And there is a serious lack of access to culturally connected crops, access to land. We're in an urban environment. Most people are living in apartments, and access to being able to build social networks, especially when you're coming into a place where, there's lots of language difference, and you are, in a place where you may or may not speak the language of the majority of the community. So we worked really closely with the city, the Department of Planning and Development, to identify unbuildable lots throughout the city. So these might be a part of a public park that hasn't really been built out yet. It might be conservation land. It might be, some other reason why there wouldn't be able to be any development on that space. And we've adopted them into a program that we developed alongside the city called the Community Gardens program. And so Mill City Grows functions as kind of like a licensor for these spaces to run the Community Gardens program on city-owned land. And it's actually a program that's open to any other citizen of Lowell if they wanted to apply. There have been some other community gardens in the city that are run by folks other than us, and that's really something that we like to let people know about and promote, that if they have a space that they want to identify, this is something that's open to everybody. And I think that, when we talk about chronic illness, which is one of the, these top level issues that we're addressing, a big part of that is access to produce, access to fresh food, and because that can really support better outcomes for long-term chronic illness, such as diabetes, hypertension, heart disease, and that is something that is usually out of reach for a lot of people in the Lowell community because of price, because of geography, or because just of in getting to know this community and finding where those resources are. It's a difficult process, and when you get to the store, the cultural crops that you're looking for, that you're familiar with and you're able to cook, might not necessarily be there. So we really work closely with the city to identify these plots, build out the gardens, and then work closely with people to create community spaces where people can grow produce, they can share produce, they can meet their neighbors. They can also, get access to education. We often have gardeners teaching each other how to grow, how to, save seeds, how to can and process things so they have food over the winter, and also just making ties within neighborhoods, which, as we work closely with all the different, programs in our city, and we understand through other academic research and communicating with our local police force that, having green spaces where neighbors gather and work together actually brings crime rates down and makes the neighborhood a safer place without any other kind of policing necessary, right? So this is a great way that we can very safely and calmly and in a really, community focused way help to improve the situation that folks are living in the neighborhoods that people are living in. We also have, really clear goals that we want to reach with folks. So we want to give them the information they need to really be able to grow. So we actually, in these 20 gardens, are able to grow about 12,000 pounds of produce per year. The community gardeners can keep that for their household, so that averages, anywhere from 60 to 80 pounds per bed that families are growing in. You also, as a kind of way of utilizing the resource of the school gardens, as you know, there's no school in session over the summer, which is when most of the produce is growing. So we're able to maintain these gardens. And in the past, they had, we've done programs where they're maintained by other community organizations or parents of students. Last year in particular, because there was such a crisis in terms of food access because of the COVID-19 pandemic, we actually created a program in conjunction with Lowell Public Schools where we grew food in 4 of the community gardens, and we're able to distribute that as a weekly share to our families that were coming to get like breakfast and lunch for their students. They could actually take home a big bag of produce every week for the entire family to eat. I think we grew over 1,000 pounds of produce in those 4 gardens, and we were able to subsidize and supplement that with produce that we were growing in our farm. And with the help of Leahy and working together, we're actually able to continue to maintain those properties so that all the beds that folks are growing in continue to be safe and sound. And we were able to add like outdoor classroom spaces so that when kids get back to school, they actually have a safe outdoor place where they can learn, so teachers can bring the students outside. So it really functions on multiple levels, where it is a place where people can get access to land, they can get physical activity, they can enjoy green space, they can meet with their neighbors, they can share learning and get education, and really taking advantage of this like resource that was very much underused beforehand. And I think that idea of like growing social capital is really one that's very important to us, because we want to make sure that folks there's a great you're able to grow community around food, because everybody needs to eat, and that is a place where no matter what your differences are, people can come together and learn from each other and experience that joy of eating in community. So over the past year, there were over 7,000 people that interacted in our gardens in some way. 450 of those are our community gardeners, and the rest are students and their families that we work with. We worked with 60 volunteers that helped us do all of this maintenance in our gardens. And we're able to, through self-reporting from the people that participate in our gardens, know that 52% of our gardeners are increasing their physical activity outside. 48% are eating more fruits and vegetables. And 75% report that they learned something about growing food and preparing food that they didn't know before. So there's real advantages to this in terms of like what folks are learning today and what they're going to carry with them into their future, in terms of being able to increase the amount of produce they're adding to their diets, and really managing those, whether they are diagnosed with chronic illness or predisposed, and trying to prevent that. This is a kind of a gateway to accessing something that may not be as easy to access just because of the geography and the different ways that people are kept out of the food system in an urban environment like this.
Thank you so much, Jessica, for sharing that, the multifaceted nature of this program and the many impacts that it's had on the community. Michelle, I'd love to get your take on how Leahy works with Mill City Grows to demonstrate the impact of these sort of investments in social determinants of health and the target populations that you've outlined in your CHNA and implementation strategy, and how this partnership engages community members in the implementation of this sort of programming.
Yeah, absolutely. Thanks, Noam. And I would say that really the bedrock of everything is it starts with having a partner whose goals are aligned clearly with our implementation strategy, and who also has a real desire and deep desire to show impact of their programs. Mill City Grows in their mission has increasing access to healthy foods as something that they want to work towards. That's clearly aligned with our implementation strategy. Their population's focus also clearly aligned with our implementation strategy. And when it comes to assessing impact, we always try to work with our community partners on metrics and building evaluation capacity whenever possible. As a hospital, while simultaneously balancing the things that we need to report, our hospital's strategic objectives, the objectives of the system. And I think that really, in working with our partners, our hope is to, you know, not only be able to demonstrate impact for us, for our implementation strategies, but also for the organizations themselves. That, you know, being able to kind of see the outcomes of the programs. And I, you know, Mill City Grows has had, you know, amazing outcomes throughout the process, as Jessica just went through. But further down the road, going for, you know, other grants or expanding programs, it'd be something that is beneficial to them as well. You know, as I said, Mill City Grows has always done an amazing job in having realistic and responsive metrics for measurement that make sense for their population of focus, and also are in alignment with what we're looking to assess for program impact. And they really have taken the lead and have been fantastic partners at working collaboratively with their populations of focus to ensure that the evaluation is appropriate, that they're going to be able to do it in a way that is responsive to the needs of people who are participating, but also being able to get us some real great data and real great outcomes while doing that. So I think that that's been something that they've been fantastic at doing, and has made it easy for us as a hospital to then consistently go back to them for further programming, for further partnership and collaboration, because they do have such great data. So we can make a data-informed decision when investing in their programs. And as Jessica kind of shared at the outset, you know, we really do have a long-standing partnership with them, and that long-standing partnership has really been what's allowed us to be able to kind of build and work with them as program partners to really drive and know what's best for the populations that they're impacting.
Thank you so much, Michelle and Jessica, for sharing some of your insights and lessons learned from this partnership. I don't see any questions just yet for the two of you, but please, to the audience, please keep them coming in, and we can circle back to this partnership if folks have a question. And last but not least, let's turn to the Men of Color Health Awareness Coming Home program. So Katie, let's start with you. How has Health New England considered the short and long-term impacts of the MOCA Coming Home program on health disparities and target populations that you've identified in your documents? And how do the goals of this investment align with Health New England's overall health equity mission?
Great. Well, thank you for having me. I hope everybody can hear me. So MOCA received Health New England's Where Health Matters grant back in 2019. So our Where Health Matters grant process is a very comprehensive program that aligns with not only Health New England's community benefits mission, but Health New England overall as a whole. And really the intent of the MOCA program, as well as all of our programs that are funded, you know, the intent is to encourage programs that address health priorities, such as social determinants of health, improve health equity across our priority populations, that bring value to our community organization. So by providing our grant recipients with education and technical assistance in the planning implementation of their grants. So over the course of their grant cycle, they receive technical assistance. Incorporating a population health perspective, really on driving health improvements using evidence-based methodology. So as Jeff had spoke to earlier, you know, the curriculum is the best practice. So knowing that the outcome of the program and the curriculum is based on data. On facilitating collaboration with community partners, so leveraging our existing relationships to develop new programs, extend the capacity of an organization, and really integrate the programs to hopefully expand their services and to really have a greater impact on their target populations and the community overall. And really the program focuses on sustainability to really strengthen the program's impact and move that needle in community health outcomes, because that's really the overall goal is, right? So Health New England also does our CHNA, and every 3 years we really want to see how we can measure and improve, are we doing what we say we're going to do? And then as we look at those goals for our program, we look at our own values. So our values in equity, impact, and sustainability were at the top of the list when we were internally looking at what matters the most for our Where Health Matters grant program. And our process, review process is very transparent. When the reviewers are reviewing grants, we really ask them to focus on equity, health equity, and the impact, and looking upstream and downstream and sustainability. So again, it's very transparent, but in the review process, we have both internal and external community members. So internal, we have behavioral health experts, legal, our case management nurses, social workers, public health experts. But to go back to the community voice, it's really important to have a community voice in that decision-making process, both lived and worked experience. Having diverse voices and backgrounds and having those seats at the table is really the first step at implementing a health equity framework when we talk about equity. And we really want to make sure at Health New England that our process is built on the foundation of equity, and not just funding a program and partnering with community organizations that are addressing health equity. So it really, again, starts at Health New England and the base of what we're doing. So again, MOCA was funded with the grant program back in 2019, and to look back at today, with where we are, and at Health New England, just a little over a year ago, we had implemented a diversity, equity, inclusion, and belonging committee that has really incorporated HME's overall mission, values, and strategy, and what we do on a day-to-day basis. And it's built on a 5-pillar system. So focusing on engagement, corporate responsibility, our own associates, recruitment and retention, advancing health outcomes, and the 5th being community engagement. So really, MOCA's program really addresses and complements not only our community benefits, but what really Health New England is doing overall at the strategy from our DEIB lens. And we're just really happy to partner with Jeff and MOCA and been able to support them.
Thank you so much, Katie, for providing that overview and cluing us into Health New England and how this program overlays with the overall mission. You talked a lot about sustainability, and I think that's a good segue to my question for Jeff. So Jeff, as you said, the MOCA Coming Home Reentry Program seeks to connect formerly incarcerated men to community-based programs and mentors who have successfully transitioned after incarceration. I wonder if you can talk about how MOCA approaches building these participant and mentor networks and how this contributes to the program's overall impact and sustainability.
Yeah, I mean, it's a really great question and something that I think about pretty intently. The first thing I do want to mention is that MOCA has been engaged in a R01 research project through the University of Massachusetts, and so I'm going to talk a little bit more about things that are kind of lofty ideas and more anecdotal evidence, but we are invested and engaged in community participatory research project that is in its 5th year right now. Building participant and member networks is not something that's easy, obviously, because we're all trying to do it. But I think it starts in one spot, and that's with transparency for the organization. And in our organization, what's native to that is vulnerability. So I think sometimes when I talk about MOCA, I mischaracterize what the organization is really about, right? We're talking about health disparities and how to engage men in healthy activities, but really we're talking about the socialization of boys that become men, and then thinking about how that socialization connects to their health outcomes, right? And so for us, it's really about challenging and not always disrupting, but challenging ideas around patriarchal thinking and how we receive ideas as men, and how we internalize things, and then how they become what could be sometimes negative outcomes or beautiful positive outcomes as well. So that idea of vulnerability in engaging with people, with men, is native to our process. In the first class you come in, we talk about unpacking the man box, where it's an activity where you talk about what it is that you've been taught is to be a man. And we start to look at those things and readdress and look at them from a different point of view. And in those conversations, we'll find that a lot more connection between the men than in talking, a lot of times what happens in this curriculum, you have like these didactic classes where people will talk to you about social determinants of health and about the foods you should be eating, which is all important. But the reality of the situation and where we're talking about really actively making change in not only men, but all people's lives is when connection is made. And so if we're able to make connections in those places, then we start the process of really making sure, building this participant and member network, right? Because we're connected to each other in that way. So that's one thing. Vulnerability, transparency, ownership is probably the second most important, right? So giving people the opportunity to know that their decision, their ideas have real decision-making power. In fact, MOCA steering committee, which leads the organization, which is the central engine of the organization, is made up of all mentors who have been through the process. Now, these are mentors that have been there for some time, and we're working on formalizing engagement around introducing new people and new blood to the steering committee, but that has always been lifted up by the men of the community. It's not, folks from whatever community organization, your VPs and which is all important. It's important to have those connections, but to run the organization in a way that is meaningful to community, it has to be driven by community. And then I would think the third thing is to add value. And that's a bunch of different ways, and to find value in the people that are participating in the project. So that's as simple as, we engage in pre and post surveying whenever we do any type of curriculum. So we pay guys for that because that information turns into dollars, right? When we take that information and say we've been able to take men from this place to this place, we write those in grants, and those turn into dollars for the organization and for the men. So we pay the men to do that. And the other part is to pay people to work. I mean, I know it's a crazy concept, but I think a lot of times when we're engaging in the type of work that we do, when we're engaging with people to make changes in their community, a lot of times it's felt as, well, that should just be something you engage with because your community needs it. Now that's real valuable work, right? And if you're going to engage in this process with us, we want to pay you to do that. So I think the three things in building, so, transparency, vulnerability, being the build connection between people, ownership or a path to ownership, a path to thinking that you can be part of the decision-making process, and pay people for their work. I think those are three pretty central and good ideas. And then once you get those people engaged in that, now we can talk about engaging in activities to be advocates or to make actual policy or legislative change. But I think it starts there, where we build that community of people around those things, and then we can take it to the next step.
Thank you so much for sharing that overview. We've got a question that I'm wondering if, Jeff, you could just answer, jumping right in. Mike asks, what an awesome program. What is the average length of time that MOCA stays with the participant? And what is HNE's time commitment to this sort of initiative? So Jeff, I wonder if you could talk a little bit about the sort of the life cycle of this sort of program.
Well, if I had the MOCA guys here, they would say they're MOCA men, right? So once you go through the process, you're a part of the organization. Whether you've just been a graduate and you're in community and we see you and you've been a graduate, so we know you, or you actually become a mentor. And that's the other part of this, right? And when we're talking about changing people's lives and the will and want to make noticeable and marked changes in their lives, we have to connect them to something more. And sometimes it's just, some hours to work to do outreach or to be a part of something larger than themselves. And, that's what's most important to us. Did I answer the question? I think I'm.
Yes, thank you so much. That's helpful. Well, I invite folks to continue submitting questions. We've got a little bit of time. I did want to read a comment that was left by an audience member because I think it really captures a lot of what's been shared today. So Aisha wrote, the work of these groups centering community voice and leadership is excellent. Thank you all for providing these examples of centering equity and centering the community in community benefits work. I couldn't agree more, and really thank you all for sharing these perspectives. I want to give folks a little bit more time to submit questions, but if I don't hear from anyone, like I said, all the questions that were asked, we'll follow up on them, and are happy to connect folks in ways that are productive and meaningful with folks who've shared their insights today. I did want to make a quick correction at the start of this webinar. I mentioned the FY20 reporting deadline. I just wanted to clarify that deadline is July 1st, Thursday, July 1st. That's why on the FY20 reports will be due. My apologies for the confusion. So I don't see any more questions coming in, but I really want to thank all the panelists for sharing your valuable time and expertise with us. And thank you especially for all the hard work that you're doing to address health inequities and make an impact on social determinants of health at the root level in your respective communities. Thank you to all the hospital and HMO staff for joining us for today's webinar. We hope that you found this event to be informative and helpful in thinking about how to improve your own community engagement practices or how to further integrate an equity lens into program planning and implementation. As I said at the start, our community benefits team will be sharing a link to the recording of this webinar very soon via email. And in the meantime, please don't hesitate to reach out to our office with any questions about guidelines or reporting resources. You can contact us at cbadmin@mass.gov. So thank you again to all our presenters and for everyone who's joined us today, and have a great day.